I'm just really excited for tonight's presentation. I'm all giddy. I'm just really excited.
Well, we're letting people in, so we're getting it good. Thanks, Catherine.
Will somebody give me a heads up when it's getting close to time? Because my clocks don't seem to be on here very well.
You've
Oh,
got 5 minutes right
there we
now.
go. Okay.
And nice to meet you, Dr. Swearingen and Sarah. I'm Sharon Taylor, the president of NAMI Johnson County.
Hi,
So
very
excited to hear your program.
Yeah.
Thank you for stepping up and volunteering your time tonight. Appreciate it.
Thank you for asking me and inviting me.
It'll be great. Appreciate it. And Sharon, are you going to open and then I'll do the announcements and then you'll do the
Yeah,
intro?
I'll just do the greeting. And
Okay.
I know that Vicki was having an issue. She didn't have the Zoom link, so I sent her the registration link.
Oh, she's on now.
Okay.
Yeah, she's good now. Okay, perfect.
Don't know how many people registered for this.
We had 21 registered.
Great.
Yeah. And so, and then, hi, Linda. There will be people who pop in last minute, because I sent out a Facebook reminder and things like that. So,
Cool.
yeah, so it'll be good.
Sarah, can you speak? Hi, Sarah.
Hi.
Are you related to Georgianne?
I don't think is it on the Delizel or Fitzdom name?
Your name is pronounced Delizel. I apologize.
No, you're fine.
It's an
Delizel is a
unusual
common
name,
name.
and I went to grade school with a girl whose name was Georgianne Bergens, and then she became a Delizel.
Oh, that's cool. Yeah, I just became a Delizel myself.
Okay.
So, but
Never
as I
mind.
know, none of them are. There's none of those in our family.
Thank you. Nobody
Yeah,
named,
of course.
but thank you for coming anyway.
Of course. I'm very excited for tonight. I think it's gonna be great.
at 7 o'clock, so I think we'll go ahead and get started. I want to welcome everyone for being here this evening. I'm Sharon Taylor, the president of NAMI Johnson County. We're happy that you've joined us for our first Tuesday's education series. And I know that our executive director has some announcements. So Kelly, if you want to give us announcements, and then we'll let Vicki or Catherine introduce the speakers.
Excellent. Welcome, you guys. We are very excited for tonight's presentation. And we just want to tell you a little bit about NAMI Johnson County if you are unfamiliar with our organization. But we are a nonprofit organization that is focused on bettering the lives of those people who have mental illness and their loved ones. We do that in a number of ways. Through support, we offer in-person and virtual family support groups, as well as connection recovery groups. We have educational classes like our Family to Family and Basics, and those are offered throughout the year, both virtually and in person. We also have advocacy, where we have our resource line available to help find local resources, and we support our crisis line 988. We do lots of events and presentations just like this one. So our monthly educational webinars are, and we also do customized presentations for workplaces, faith communities, or schools. And then, of course, there's many volunteer opportunities. So NAMI Johnson County is a great place to give back to your community. We do some incredible training and get you equipped to share that hope that you've received and that community that you've received through NAMI Johnson County. So if you're ever interested in leading a support group or a class or a presentation, we want to help you do that. So don't hesitate to reach out. We do have a number of upcoming events. Tomorrow, actually, we start our next in-person family to family class. This is an 8-week class for those people who have a loved one with a mental health condition. It starts at 12:30, goes till 3 o'clock, and that's at Knoll Avenue Church of the Nazarene. If you're interested in registering for that, please go to namijoco.org/calendar. We also have a virtual basics class, and this is for parents who have a child with a mental health condition. This is a 6-week class, and it starts on March 27th. It is virtual. So once again, you'll go to that namijoco.org/calendar to register for any of these. We have our book club starting March 11th at 6 o'clock, and the story or the book that they're going to be covering is While You Are Out, which is an intimate family portrait of mental illness in an era of silence. This is a great group. They have some really great discussion, and I would just encourage you, if reading is your thing, this is a fantastic way to get involved in NAMI. And then, of course, I want to highlight one of our national organization, their events called Ask the Expert. And Dr. Xavier Amador will be presenting on I'm Not Sick, I Don't Need Help. How to help someone with a mental illness accept treatment. This is a major concern, an area of what we deal with in NAMI, and his work and practice is fantastic. He's a dynamic presenter, and so I highly recommend that you attend this webinar. It is through our national site, so you will have to go to nami.org and just search for Ask the Expert, and it'll be right there, and you can register there. It's at 3 o'clock on February 15th. So please consider doing that. Everything we do is free. Thankfully, we are a nonprofit, and we are grateful for our generous donors and our grants. Next month, on our first Tuesday educational series, we will have Remarkably Resilient with Kathleen Harnish-McCune and Tim DeWeese, talking about raising community awareness about resilience. Please go and register for that. It'll be a fantastic conversation as well. And then, of course, stay in touch with us. We do send a weekly newsletter. So if you are getting those weekly e-newsletters on Monday, it's a great way to register and see any new events coming up. And then, of course, we have our local resource line. So if you needed to talk to somebody and find some local resources, don't hesitate to call. And then, of course, our social media. So without further ado, I will pass it off to Sharon. Thanks for joining us.
Thank you, Kelly, for giving those great updates. We do have some fabulous programs. So I hope that you will take advantage of those things that interest you and that are available to you. So Catherine or Vicki, who would like to introduce our speakers this evening?
I can go ahead. We have a real treat tonight. I don't have any other way of saying that. We are really lucky tonight to have ED Care Kansas City joining us. Dr. Sheila Swearingen being our presenter for the evening. As someone who has lived experience in recovery from an eating disorder, as well as a mental health professional, I've had the honor of getting to hear Dr. Swearingen and ED Care Casey present on a number of times within both of those roles, and they are incredible. So buckle up. We've got a great session tonight. It's going to be amazing. We're so lucky to have them. A little bit just real quickly about our wonderful presenter, Dr. Sheila Swearingen. She is a licensed psychologist in Missouri, Kansas, and Colorado, which is amazing. She also has a master's in clinical psychology and a PhD in counseling psychology from the University of Missouri, Kansas City. In addition to all of that, she also completed her pre-doctoral internship at the University of Kansas School of Medicine in Wichita and Wichita State University, specializing in the treatment of eating disorders. Additionally, she has experience working around treatment of eating, compulsive exercise, working with student athletes, addressing body image, trauma, and chronic health concerns. So all kinds of amazing things that we need a lot of support around here in our community. So we're really lucky to have her here. She's also a certified eating disorder specialist supervisor. So if you see me emailing often about with credential CEDS, that's what we're referring to here, certified eating disorder specialist. So we are really, really lucky to have Dr. Swearingen tonight and Sarah from ED Care. I'm so grateful for you both and all that you do for our community. And so without further ado, I'll go ahead and turn it over to you.
Well, thank you very much, Catherine. That was a lovely introduction. And thank you for inviting me, Johnson County NAMI, and all of your supporters and individuals. It's quite an honor to be able to share some information with you. I'd like to make it kind of a dialogue. So, you know, this is a lot of information. I'm not certain what everyone's familiarity is with eating disorders in particular. But, you know, we do want to be able to share whatever we can to make sure that you have enough information to, let's say, understand at least in a walking fashion what's going on with an eating disorder and related issues. And I think, Catherine, you said that you might be helping me with questions or something along the line.
I will. I'll be monitoring the chat and adding resources as we go.
Okay. So I can't see everybody, but I hope that you can see my screen. So title slide should be up, Eating Disorders 101, How to Help a Friend or a Loved One.
Yes, ma'am, they are up.
All right. Okay. Well, let's jump into it. So, you know, as Catherine said, I'm with ED Care. I've been here with ED Care since 2015 in a variety of roles. My objectives here for this evening are to help everyone learn a little bit more about eating disorders, how to identify them, what co-occurring disorders are, their adaptive functions for our patients, to also provide maybe a very brief explanation of what Health at Every Size is and the relationship of HAES within the treatment world of eating disorders. And finally, to also be able to provide some information about how to help someone with an eating disorder, some information related to ED Care, what we offer, as well as how to maybe potentially practice a little self-care if you're a support person or a caregiver yourself. So without further ado, get my slides moving. So for disclosures, I have no conflict of interest to disclose, and to the best of my knowledge, there are no limitations to the content within my presentation. You know, there's a lot of discussion about eating disorders, what they are, and confusion about what they aren't. And it's really something to consider that this is a very serious illness. It's a mental health illness. It's a medical illness. It's very complex. And it's not uncommon to see a patient who starts out maybe in adolescence with restricting anorexia and then moving towards maybe bulimia while they're in college or young adulthood. And then perhaps later in life, maybe giving up the compensatory behaviors of purging or excessive exercise, and then maybe engaging in binge eating behaviors, and then moving, through the whole dynamic of, into something that we call OSFED or other specified feeding or eating disorder, which is still a very clinically significant eating disorder, but doesn't meet the criteria for one of the other major diagnoses. But we do see that it's a transdiagnostic migratory sort of illness and encompasses really everyone, all ages, all genders, all socioeconomic statuses, ethnic experiences, everything. Eating disorders are not discrete. About a third of individuals with bulimia also meet the criteria or previously met the criteria for anorexia. And we have to take into account that, there's a lot of comprehensive information to get through this. I'm not sure if we'll have like a call and response. So I do have a few slides. If you're able to respond, that'd be great. But I'll assume that you are. So everybody out there is probably very clever and will understand the answers to these questions very easily. But I thought we could start with an informal check-in. What do you know, or what do you believe you know about eating disorders? So true or false, you can identify someone struggling with an eating disorder simply by looking at their appearance, observing what they do or they don't eat. Any thoughts on that? The answer might be false. Many people mistakenly believe that individuals with an eating disorder are either exceptionally thin or severely obese. However, there's a lot more individuals of average size and weight that struggle with one form of an eating disorder or another. So people with eating disorders, again, they come in all sizes, ages, gender expressions, ethnicities. Certainly rates are higher among females, and symptoms are commonly seen more in adolescence and young adulthood. But we do have to recognize that they are not something so easily identified. BMI alone or somebody's weight is not really a good sole indicator of someone's health. There's a lot of factors involved. We'll get into that a little bit later. True or false? Eating disorders are caused by unhealthy, unrealistic images within the media. A lot of people want to, say that TikTok and Facebook and all of those things and everything maybe, is to blame, but, certainly has a role. They contribute. But I think there's a lot of historical perspective that we need to understand about eating disorders that occurred well before we ever had social media as we know it. So the answer is false. One of the earliest cases of anorexia was cited in the medical literature by Dr. Richard Morton, who described a 20-year-old woman that he was treating in 1686. So eating disorders have a well-documented medical experience in the literature, but they have not always been really understood well or how to treat them. In 1868, Dr. William Gall described a very strange malady that he called apepsia hysterica. And it seemed to only afflict young women who refused to eat, even as they became extremely emaciated. Well, he continued to do research, and 6 years later, he revised his findings, and he gave the illness what he found, the name that we know now as anorexia nervosa. Another very, very interesting research study that was done in 1999 by Dr. Ann Becker of Harvard University. She went to the Fiji Islands, and she was studying kind of the cultural experience of Western culture on let's call it a virgin sort of cultures, individuals who had not been touched much by the Western individuals. And so in 1995, television was introduced on the Fiji Islands in the South Pacific. And so she went there and she, started her study and interviewed a lot of individuals and found that about 3% of girls who were there were reporting using vomiting to control their weight. This is a longitudinal study, so she went back a few years later. And what she discovered 3 years later 15% of these young women that are on this island are reporting the same behavior. And as through the course of her research, the symptoms of the eating disorder had increased 5 times, fivefold over, this course of just introducing television to the South Pacific Island. So, this is certainly something to take into account, that the media, whether it's print media, television, social media, it does have an impact, but it's not the sole cause of what's going on. Eating disorders are all about food and body image. Well, certainly diet culture and dieting behavior can be an initiating event for a lot of individuals, but eating disorders are very serious mental illnesses. So the answer is false. It's not just about the food. Eating disorders are seen as a coping tool or a skill. It seemed like a reasonable solution at the time when someone is feeling that they had limited options for managing a difficulty or a problem in their life, until it becomes its own problem. And so, an individual that has an eating disorder, they have a lot of things going on. They feel very limited in their power of what they can do to make change in their life. And so using a inappropriate coping tool, much like somebody maybe reaching out for an addictive behavior, alcohol or drugs, it seemed like a solution at the moment, and then they get caught up in the illness, and it's hard to get out. Eating disorders are an attempt to call attention to oneself. Well, a lot of individuals maybe are trying to find a way of expressing their distress through an activity, maybe through trying to make change in their body or manipulating their food. But the reality is the vast majority of individuals with an eating disorder don't want to draw any attention or focus to themselves. They have so much shame and embarrassment. There's a lot of guilt for engaging in the behaviors that they do. So that is the least of what they want. Shame and secrecy for this illness leads to denial, which leads to underreporting of illness symptoms, leads to misdiagnosis, and eventually inadequate treatment. So much like any individual with a mental illness, there's a lot of fear of being stigmatized by labels related to their illness. It's important to recognize that people do not choose to have an eating disorder. Nobody really sets out and goes, I think I'll become an anorexic today. It's usually a very, very quiet illness that sneaks up on somebody. And if somebody is vulnerable, risk factors within their life, they may succumb to what's going on with the eating disorder, and it takes hold. More to come later in the presentation. My last question for you: people can recover from an eating disorder. And I want to leave this question with a bit of hope. Yes, true. Long-term recovery from anorexia is very possible. It tends to be a bit protracted, so it could take 3 to 5 years of active ongoing treatment. But the good news is about 70% of individuals with appropriate treatment will recover. So that's really, really positive news. It's a lot more than just willpower. And recovery is going to take a team, and there's going to be a lot of interventions and appropriate care that has to happen for improvement to be noticed, but it is possible. So some more facts. I have lots and lots of facts for you all, but let's review just some basic facts around eating disorders. Some of these, maybe some of you are familiar with, maybe this is all new to you. But from almost 1% to 2% of females and 1/10 to 3/10 of all males will develop anorexia. And males represent 25% of our individuals with a diagnosis of anorexia nervosa and have a much higher risk of dying from this illness because professionals assume that anorexia nervosa only afflicts females. Another statistic that I really want to draw attention to is the information related to binge eating disorder. We have a lot of individuals, 3.5% of women, 2% of men, and 1.5% of adolescents who are diagnosed with binge eating disorder. And we have the awareness that binge eating disorder itself affects more individuals than anorexia or bulimia combined. excuse me, about 40% of individuals with binge eating disorder are males. And the median age for onset of most eating disorders is 18 to 21, again, adolescents, or, you know, for much of anorexia, even younger, 12 to 15. But the median age for binge eating disorder is more common after the age of 30. So adults. 95% of all dieters are going to regain their lost weight within 1 to 5 years. And I really want to point out that our children are being bullied and teased about weight by not only their peers, but also by family members. So weight teasing is going to predict weight gain, binge eating, and other extreme weight control measures. You know, we have to be mindful about what we're doing and how we're doing it. And our children are very, very concerned about their weight. They're afraid of becoming quote unquote fat. And this is an issue that persists throughout their life. This is something that, you know, again, we really need to look at prevention and how to manage that. Of all patients coming to the attention of mental health professionals, 90% of them are female, 10% are male, you know, but what we can recognize is that of all women who diet, 76% of them are doing so for cosmetic reasons and not about health. And about 50% of individuals with an eating disorder also succumb to using alcohol, prescription drugs, or other illicit drugs, which is 5 times higher than in the general population. We also see a high incidence of individuals who have been victims of assault, whether within their family or by others through rape or incest. And a number of individuals that we see for treatment have unresolved trauma and or PTSD. And so these can also be perpetuating factors for maintaining their eating disorder. So again, shame and secrecy of this illness, it's going to lead to, again, denial, underreporting, misdiagnosis, and then inadequate treatment. This is the most important slide I think I've ever seen, and I share it often. And unfortunately, I've had to adjust it a bit. Up until just a few years ago, anorexia nervosa had the highest mortality rate of any psychiatric disorder, bar none. This is now being shared with opioid addiction and deaths related to opioid drug use. So anorexia now has the joint highest mortality rate of any psychiatric disorder. In 1998, there was a study in the Excess Mortality of Mental Disorders Journal, and they found that the highest risks for premature death from natural and unnatural causes are from substance abuse and eating disorders. And in 2014, results in the risks of all cause and suicide mortality in Mental Disorders Journal, they looked at 1.7 million patients, and of those 250,000, a 250,000 deaths, and they were able to conclude that individuals with the highest all-cause mortality ratios were substance use disorders and anorexia nervosa. So again, eating disorders are serious. They are deadly. I want to help you all understand a little bit of how to recognize an eating disorder. So some of the the types, these are the clinical labels for the most current identified eating disorders in the DSM-5. And we're just going to do a kind of a brief review of each of them individually. Some of these, again, may be more familiar than others. Some of them are newer. So for anorexia nervosa, this is one that most people are very familiar with or believed to be so. Generally speaking, this is an illness where somebody is not taking in enough calories, which leads to low body weight. And this is in context to their age, their gender, their developmental trajectory, and what their general health status is. Along with inadequate nutrition, there's an intense fear of being fat or gaining weight, even though they are visibly underweight. They have a distorted body image. And so although they can look in the mirror and see themselves, they see themselves in a much larger body than what is actually there. Again, the changes to the brain chemistry create this disturbance in their perceptual abilities about themselves. There's also a very high focus on body shape, weight, and size. And most individuals with this disorder lack any recognition about the seriousness of the illness or their particular symptoms. So they're always quite in denial related to, really, I'm fine, everything's okay. This is, you're worrying too much. With DSM-5, there has been a breakdown of the diagnosis into two different types, restricting type and binge eating, purging type. So with restricting type, this is generally identified that within the last 3 months, the individual is not engaging in binge eating or purging behaviors, and their low weight is produced through strictly dieting, fasting, or excess exercise. The binge eating purging type, again, in the last 3 months, the individual is regularly engaging in binge eating and purging, and that's usually through vomiting, laxatives, diuretics, or enemas, or other methods of extreme body change. Something to note with anorexia is that we do see a presentation of bimodal age of onset. So we see it happening in the very, very young and young adults, and then again later in life in a more mature individual. So again, maybe somebody as an adolescent is using eating disorder behaviors to cope with life transitions at that time in their life. And then maybe as things progress later on, they may return back to those behaviors that they once had, or maybe some transmutation of them. I want to emphasize that, like this slide, there is a lot going on with an eating disorder. Eating disorders affect all systems of the body. It's not just about the weight. And so I hope, I know this is small print, but I'll try to kind of read it for you. The brain and the nervous system are going to be affecting, what is happening. So mood is going to change. People are going to be irritable. They're going to have poor memory. Maybe there's going to be, again, that fear of weight gain. They're not thinking clearly. Their hair is impacted, their fingernails, their skin is impacted. The hair is thinning, it may fall out, their skin bruises easily, it gets dry. They develop a pelt, basically, because their body is so low in body fat. Survival of the internal organs would require that the system is going to try to do whatever it can to provide some warmth. So it's going to grow a very fine hair all over the body, which for many of our patients is, again, part of that humiliation, because that's not something that they thought was going to happen, but they can't stop it. Heart is impacted, muscles and joints, their kidneys, electrolytes, their body fluids, their intestines. A lot of our patients, again, they're complaining about constipation or diarrhea, or, pain and distress, and they may go to the doctor and complain about, I'm having a lot of constipation, and so the doctor gives them, laxatives because we want to stop the constipation, but nobody asks them about their eating behaviors. And so this just kind of reinforces what's happening and keeps the eating disorder alive, so to speak. With bulimia nervosa, again, very similarly, eating a large amount of food in a discrete amount of time, which is usually more than what's done in about a 2-hour period of time. And there's a sense of lack of control while eating. So typically, somebody with bulimia nervosa is then going to engage in a compensatory behavior. So they're going to either fast or restrict, or they're going to engage in self-induced vomiting, using laxatives, diet pills, or engage in excess exercise. Again, what's important here is that sense of lack of control around eating, feeling that they couldn't stop themselves if they tried, no matter, what's going on here. With bulimia nervosa, the consistency of the behavior is important. So the behavior is occurring at least once a week for about 3 months. And again, the compensatory behavior is an effort to avoid weight gain, and to try and, again, change the appearance of the body. So much like anorexia, again, every system's going to be affected by the behaviors of bulimia. So again, anemia, the heart is going to be impacted. Maybe there's going to be arrhythmias, low pulse, blood pressure. The muscle is going to become weakened. It potentially could lead to a heart attack or just complete heart failure. Body fluids, dehydration, low potassium, low sodium. These, again, those are electrolytes that are important to the health of the heart. Intestines, constipation, irregular BM, diarrhea, abdominal cramping, all of the same, kind of complaints. Hormones impacting menses, fertility, all of these things are happening. Because the individual is vomiting potentially, there could be changes then to the cheeks. We get something that's called like chipmunk cheeks, where is kind of a swelling of the parotid glands. The individual's glands in the cheek area are filling up basically with vomitus and emesis. And this is just a side effect of that behavior. Cavities, tooth erosion, gum disease, sensitivities for heat and cold of their teeth, potentially ruptures within the throat, the esophagus, or the stomach. So all of these things, again, these are all very serious medical complications for this mental health illness, you know. Eating disorders are serious. Binge eating disorder, this is a rather new diagnosis within the last 11 years. This is something that, you know, again, it's hallmarked by eating a large amount of food in a discrete amount of time, much like bulimia. That sense of lack of control over what they're eating and how they're eating is also there. It also includes maybe eating faster than normal, more typical, and eating till the point of being uncomfortably full. What is different here is there is no compensatory behavior. So that's important. So they're not engaging in vomiting. They're not engaging in exercise, diuretics or laxatives or anything like that. What's important here, prior to 2013, DSM-4 transitioned to 5, and binge eating disorder was not a separate diagnosis. So it was under an umbrella diagnosis called EDNOS, or eating disorder not otherwise specified. And as I spoke earlier with the facts, we've come to recognize that binge eating disorder is actually the most common eating disorder in the United States, affecting almost 3 million adults. So we find it in normal weight individuals, overweight individuals, and obese individuals. But not everybody that's obese has binge eating disorder. You know, there's a lot of individuals that are embarrassed about their behaviors, and they're struggling with binge eating disorder, and they're not coming forward to talk about this with their healthcare providers. Again, all of these complications are very serious, and an individual may go to their doctor to address something that's happening, maybe joint pain or muscle pain, or maybe they're having difficulty sleeping, arthritis, and the doctor is going to attribute all of this to what's going on with their weight versus really asking about what is happening. And so, you know, the diagnosis of, you know, okay, you've got type 2 diabetes, let's change your diet. Let's, you know, go on a diet and eliminate all these food behaviors that you have. But not really getting into the weed of it, you know, why are their food behaviors happening? With other changes that occurred with DSM-4 moving to 5, additional diagnoses that have been added. One in particular, OSFED, it's other specified feeding or eating disorder. This has become the new umbrella diagnosis. So again, OSFED is different eating disorders with specific behaviors, restricting intake, purging, binge eating, all as features. But what's important here is that the diagnoses of these particular ones, this is about the atypicals. They're not meeting the strict criteria for anorexia nervosa or bulimia nervosa. So they're called atypical, but I don't want to paint that as being not so serious. These are very serious. They're no less serious than any of the others, and they're equally challenging to treat, if not harder. Somebody with atypical anorexia meets all the criteria for anorexia, except maybe their weight is different. It's within normal range. In fact, it could be even that they're in a larger body and an above range. But the fact is that they have lost a significant amount of weight. Same thing with purging disorder. Maybe they've been anorexic, but instead of being able to continue to restrict their food, now whatever they're eating, they're purging it. So they're not exactly engaging in binging, they're just purging, and they're, you know, continuing to lose weight. And so it's a different sort of behavior that we have to look at and consider the seriousness of it. Diabulimia, this is not a a strict DSM diagnosis or ICD-10 diagnosis, but what this refers to is a diabetic individual who is intentionally manipulating their insulin, either to change their weight or to change their appetite, all in service again of body changes to manage their weight for an eating disorder. Of note, I believe it is under consideration to be added into the DSM with the next revisions. ARFID is another newer diagnosis label. It was previously called feeding disorder of infancy and early childhood. It's sometimes referred to as picky eaters. So individuals that are diagnosed with ARFID, they significantly limit what food they're eating based on a variety of factors like texture or color, temperature, taste, maybe brand. So maybe they're only eating foods that they don't have to chew, or maybe they're only eating foods that are like vanilla colored, or maybe it's the temperature, they're only eating foods that are hot, or maybe only foods that are cold, or maybe none of the foods are salty, or maybe they're only eating French fries from McDonald's. It's important to recognize that, again, the significant weight loss, nutritional deficiency, maybe dependence on a supplement like Boost, and the illness interfering with somebody's ability to function in their daily life. This is what's important, is to remember this is a serious eating disorder as well. Oftentimes, this particular diagnosis is paired with individuals who may be on the autism spectrum. So again, texture and sensory issues are paired with what's going on for this particular diagnosis. Usually individuals with ARFID also, though, they don't have concerns so much about their weight or their body size. So that's a little different than maybe an anorexia. I wanted to touch on purging via compulsive overexercise. I mentioned that before on a number of things. What this is about is somebody who is using the exercise behavior as a driving force to manipulate their weight, to lose weight. Obligatory refers to something that an individual will do at any cost, no matter what's happening, whether it's the weather, illness, the holidays. It could be, I'm supposed to be going on an anniversary dinner with my husband, but I darn well better go out and run 10 miles because we're going to go to this fancy restaurant where I'm going to eat food. So, exercise isn't about fun or pleasure. The individual engaging in this is never satisfied with their physical achievements. This is strictly about in service of an eating disorder. This is to lose weight. This is to restrict their calories. They don't want to weigh a certain weight or appear a certain body shape. This is something different too with our anorexic patients who are engaging in excessive behavior. Probably 40 to 80% of them are engaging in some form of movement. And there's a lot of speculation about maybe this is about the body's, the brain's survival tactic, trying to get the person to leave the vicinity where they are in maybe famine. Because the brain doesn't understand that an individual is actively restricting their food. They just believe that there are no resources available. And so it would say, maybe if you were a caveman, okay, there are no more animals here. There's no more, berries to eat. We need to move on and migrate to the next area where we can find food. And so maybe this urgency to move is more about a survival strategy. Some recommendations if somebody is engaging in overexercise, what we try to do is a lot of education, reminding them that excess exercise is dangerous, that it potentially could, impact their health in a variety of ways, stress fractures, that sort of thing. We also want to be able to set limits around what is happening and how much exercise, just to see what emotionally comes up for somebody. So in our treatment program, we ask individuals not to exercise for 2 weeks, and we do an evaluation of, what's happening for them. And we can recognize, if it's like no big deal, if actually they're kind of relieved, it's like, oh, thank goodness I don't have to do that anymore. We might then start looking at how to reintroduce in a modest way more movement for, again, finding joy or for health reasons, versus somebody who is becoming quite anxious and restless because they're not engaging in the behavior and they're fearing that their weight's going to accelerate out of control. So this leads to another new term, orthorexia. So this is also not a diagnosis per se, at least not yet, but this is excessive focus on clean eating. It's an unhealthy obsession with nutrition, with exercise, with diet. It's about a mindset. And so it may be expressed in a manner like people who are afraid of eating white rice versus brown rice, that, one is healthier than the other. Or maybe there's, around their exercise that it's about the intensity or the number, or, trying to reach, I have to exercise for 55 minutes, not 53 minutes, again, getting kind of caught up in rigid patterns. Individuals like this may engage in a lot of concern around if they eat something that they perceive to be unhealthy. Again, they're labeling things good or bad. They're putting a morality label onto food. And so now they're feeling guilt after they eat something that they perceive to be unhealthy or immoral in that way. So they're going to try to punish themselves, either, again, engaging in more activity with exercise or restricting their food. I have down here love of kale, all types. This refers to a particular person that I worked with that they ate kale for every meal, every snack. They had kale for breakfast. They had kale chips. They made kale cereal. They had kale in their dinner. They put kale in everything. And they did this for quite a while. And, they were feeling very good about themselves, that they were following this very nice, healthy diet that I don't know if they found it on the internet or if some practitioner expressed the health benefits of kale. But they started not feeling so well, and they went to their general practitioner, who did a lot of medical studies on them and did some blood work on them. And the results came back, and they're like, you have this particular deficiency in your macronutrients, and it seems to be related to an overabundance of, the vitamins and the iron that's coming from kale. And so this individual was actually becoming toxic from having consumed too much kale. So again, nothing in excess is good. Everything, even good things, need to be done in moderation. We have to keep that in mind. So people often ask me, when does it become disordered eating? When, do I have an eating disorder? Is it possible? I'm sometimes skipping a meal, or maybe I'm overeating at the holidays, and so these questions are really concerning for a lot of people. But the real question is more about the impact the behavior has on your life and your health, and how pervasive the behavior might be within your life. So again, the continuum of normal, natural eating in response to your hunger, your fullness cues, accepting that your body is going to change with time because that's just what happens, all the way up to regular dieting, maybe skipping a meal here or there, following a particular regimen, to what would look more like a subclinical eating disorder. So maybe, again, occasionally binging, maybe taking diet pills, engaging in some fad behavior programs or something like that, or a full clinical eating disorder, anorexia, bulimia, binge eating disorder. So again, all eating disorders, they're serious disorders. They have life-threatening physical, psychological complications. Weight is not the only marker of an eating disorder that we need to be concerned about. So people who are at low weight, normal weight, or high weight can have an eating disorder. People at any weight could be malnourished and engaging in all sorts of unhealthy practices. It's important to consider kind of the temperament or the psychological makeup of somebody with an eating disorder. And the different diagnostic categories have a little bit of discrete characteristics among them. Individuals with anorexia tend to be emotionally restrained. There's a pervasive sense of being kind of living a joyless life. Nothing seems to be good enough because they have such high standards and expectations for themselves. They have to get all A's. They demand a lot of themselves, and they give up things that they love in service for their eating disorder. And so being a good anorexic is a full-time job. and there's really not a lot of room for anything else in their life like that they used to love, like sports or maybe writing or piano or people. They even give up space in a room because they don't want to allow themselves to be rewarded or, to take up too many resources from their peers. They also tend to be what I would say, quote unquote, unneedy. They don't want to have needs. They don't want to have any natural hunger or appetites. They're also very harm and risk avoidant, so they don't like change. They tend to be very methodical. They prefer things being orderly or predictable. They don't do well with stress. Um, they're very high warriors, extreme warriors. They're overachievers. They look for perfection, and because they're not perfect, they're going to feel worthless because they're never getting there. They also are very sensitive for approval and rejection. So if we think about positive feedback, it would be like Teflon, so it's just going to slide off of them. And negative feedback is going to be more like Velcro. It's just going to stick and you can't shake it off. So positive things are really under-experienced and negative things are over-experienced. There's also a lot of obsessional thinking. Again, they're starved. Their brain is, trying to figure out how to survive. So they're spending about 85% of their time or more thinking about weight, shape, their appearance, food, cooking, all sorts of things related to food and areas around food. They also tend to believe that they're calorie and nutrition experts many times, while they also have very little actual understanding about normal eating patterns or what would their personal nutritional needs be. So these are individuals who may declare that they're vegans or vegetarians, they're gluten-free now, or they don't eat dairy, they're not going to eat meat, or they're avoiding anything with fat or sugar. Again, back to those orthorexic individuals. And this is not because of allergies or illnesses or ethnic or religious reasons. This is because they truly believe that the calorie in a piece of meat is bigger than a calorie in an apple. So again, they have a lot of false beliefs related to food and their particular needs. Individuals with bulimia nervosa, their temperament tends to be a little bit more on the impulsive, uh, you know, uh, agitated side. So there's a high incidence of depression or emotional lability with individuals. They tend to be black and white thinkers. Everything is good, everything is bad, it's all or nothing. This type of thinking usually leads to the belief that things are right or wrong, and that that's the answer to doing everything. And so it creates a lot of ambivalence, and because the world isn't ambivalence, that's going to bring chaos into their life. They also tend to be a little bit thrill seekers, risk takers, novelty seeking, that sort of thing. And depending on who they're with, they may change their opinion frequently. Again, kind of that people pleasing method. And because they really don't have an identity for themselves outside of their eating disorder, there's a lot of low self-esteem. The behaviors themselves cause a lot of secret shame, guilt. Generally, we could say that we identify an anorexic because of how they look physically, but bulimics are hidden. Many of them are actually in standard or normal weight size bodies. Again, there's a secrecy that they don't want to share with individuals. But if you're looking in your reflection in the toilet bowl several times a week, they know that there's something wrong. The bulimia becomes their best friend as well as their worst enemy. And again, they don't have an identity apart from that. They don't know how to have good interpersonal relationships. They feel that, to protect their eating disorder, they're going to lie to the people that they love the most. They're using food to cope with whatever's happening, and an anorexic individual is going to turn away from food to cope. Again, whatever is helping them to reduce their anxiety. So, they're going to manage their emotions, their fears, their anxiety, their depression, all with food. And because they can't contain that food, they're going to get rid of it because, again, they don't want to, engage in this behavior that's going to change what they appear to look like. Individuals with binge eating disorder, they have high impulse control issues as well and a lot of emotion regulation issues, but they also have a very high need for acceptance. there's people-pleasing behaviors here as well. They're very vulnerable to shame and stigma and feel a lot of distress. They are very resistant and reluctant to share their behaviors with clinicians because, again, the belief that they're going to be judged for what's happening in their life. There's a lot of stigma and bias against individuals in larger bodies. People with binge eating disorder are usually not engaging in compensatory behaviors. Again, they have low dietary restraint, so they can't stop themselves from having a binge or, the time in between binges, but they're not going to compensate. They're not going to get rid of the food. They isolate a lot more, again, feeling judged, feeling like they're out of control. They don't know how to stop themselves. And there's a lot of functional impairment in their life. So they're isolating their personal life, their sexual life, their work life. Everything is kind of suffering for them. As with many mental illnesses, eating disorders also come with a lot of comorbidities. So we see a lot of individuals that are maybe going to have drug or alcohol abuse, impulse control, issues, shoplifting, sexual promiscuity, spending binges. So instead of binging on food, maybe they're going to swap behaviors and now they're, on Amazon or eBay or something like that. We also see a high number of mood disorders, whether depression or bipolar disorder, anxiety, and also personality disorders. We generally don't know which it is, if it was the comorbid issue or the eating disorder that comes first, but we do have to recognize that because they're both there, we have to treat both of them. A lot of our patients with eating disorders have depression. Certainly 50 to 75% have comorbid depression and 43% have comorbid anxiety. Obsessive compulsive disorder, we see that really strongly with our anorexics. Again, kind of that over control that occurs for them. Bipolar disorder, less often with our anorexic diagnoses, but more with the bulimia nervosa and sometimes with binge eating disorder. Substance use, again, this is something less common with our anorexic patients and more common with the impulse control issues, the bulimia, the binge eating disorder. But as the individual maybe migrates away from strict restricting into more purging or behaviors, we see an increase of substance use with our anorexics. So why so much comorbidity? Again, for a lot of individuals, the eating disorder seemed like a really reasonable solution for finding a way of control in a particular life problem until it became its own problem. So we have this issue where, different things are going to happen. We have this genetic predisposition, or there's complications in life, or maybe there's some kind of common cause, that's underlying this, maybe a trauma or something like that. So we have to recognize that there are a lot of variables that come into play when we look at how somebody might develop an eating disorder. What are the risk factors? There's a very strong genetic vulnerability. There's environmental factors. The behaviors all, added in together with these are going to lead to a mental illness. And we have anorexia, bulimia, binge eating disorder. And so a very common idiom that's said, that's shared, is that genetics loads the gun and environment pulls the trigger. So no matter the diagnosis. We do see that there's, a lot of evidence in research about family and twin studies and adoption studies that demonstrate the importance, if not the dominant role, that genetic factors are playing in the formation of our personalities. So biologically, there's this issue of, what might be going on. Why could 100 girls go on a diet, but only 4 of them are going to develop an eating disorder? Well, again, there's a lot of vulnerabilities that may be happening behind the scenes. So whether it's about dieting or binge eating or purging, exercise, all of those sorts of behaviors are going to change somebody's brain chemistry. Again, it's going to affect every system in the body. And so all of these behaviors over time are going to expose somebody to being more vulnerable to develop the risks related to developing the eating disorder. So, maybe some of the things that happen at puberty could play a role in this. Well, there's a lot happening at puberty. sadly, there's so much, hormonal changes that are happening, and kids don't get a lot of information. Um, Adults don't have a lot of information. They don't know how to talk to their kids about what's happening. There's factors related to their peers, sexualization. They're noticing that somebody's body is changing or their own body is changing. Um, Nobody talks to our adolescents, especially our girls, that at puberty, they're going to start developing physically and sexually, and what that means completely. And so if you think about the 4 years between ages 11 to 15, which is like quote unquote normal female puberty, an individual female girl is going to, on average, gain 10 pounds a year. That's 40 pounds in 4 years. That's mind blowing. If you told a kid, you're going to gain 40 pounds in 4 years, they're going to tell you you're wrong and you can't make me. If you tell a parent that, they're going to say, oh my gosh, I have to stop this. There's something wrong here. But the reality is, no, that's everything that's right. That's what normal is we want our kids to grow into full grown adults, not be, toy poodles or something that we're trying to squeeze into a compact body. So we have these risk factors.
Swearingen.
Yes.
Would there be any recommendations that you would have for people that may have children or children in their lives going through puberty, of the language used around puberty about their bodies that would be more helpful than harmful around those changes?
Sure. The thing to keep in mind, and we could all probably think back to our own, maybe the talk with our own family members or support person or whoever was brave enough to share that story, with us as we were growing up. And if we're uncomfortable talking about something, we're leaving it up to other people outside of the family or ourselves. We're giving away control, so to speak, to the kid's going to find the information themselves. And so let's talk about the truth. Let's go to the doctor and maybe, the pediatrician and say, okay, so we need to start talking about when puberty might happen or when, we could expect this to happen. And let's talk about what's kind of normal about that. And so much like when we have an infant, we don't expect them to stay maybe 8 pounds for the first year. We would be horrified if that were to happen, Um, that's a problem. And so we, tell parents, okay, we need to expect them to gain X number of pounds, between visits, and this is what should be, seen, and we're going to be monitoring that and keeping an eye on it. Well, we need to have that same conversation ongoing throughout the child's life into moving into young adulthood. And, when do you expect that they're going to stop growing? Well, it could be 20 years old. You're going to grow taller, you're going to, maybe develop shoulders. If you are engaged in an activity like swimming, a lot of that's going to change, kind of your body makeup. If you think about somebody like, oh, I can't even think of his name right now. Very famous swimmer from the Olympics.
Michael Phelps.
Thank you very much. I was going to worry about that all night. I mean, if you look at his body torso, his shoulders are very broad and his arms are very long, and he's been developed to become a fish. But if we look at most kids, they don't look like that unless we kind of get them involved in different things and what's happening. Gymnasts tend to be very small because, again, they're engaged in this behavior, which is limiting what their, nutritional food might be. They're engaged in activities of pounding, so their body is getting used in a certain manner that creates changes. So we have to talk about what is a normal expected change. And so we want to see that when you start, maybe developing your secondary sexual characteristics and, not scream from the room, but that means that you're going to start growing hair in places that you didn't think you would. And maybe you're going to start having body odor. And along with that, it's going to be, just you're going to grow taller and your feet are going to grow a little longer and your arms are going to grow longer and your shoulders are going to grow wider and your hips are going to grow wider. And you're going to be, developing into a human being that's going to be ready to have a baby when you're an adult. And what that means is your body's got to put on some body fat to be able to protect your organs. And what does that mean? You're going to be gaining a little bit of weight. And so just talking in a very normative kind of way about we expect this to happen. not like this is a shock and oh my gosh, what happened? You know? And so watching your child fall down, if you react with, a gasp of horror, your child's going to think, oh my gosh, I should be worried about this. But if we talk about this is just normal, having the talk about menstrual cycle in a very normative way, um, not making it only a girl's thing. It's something that the family talks about, that changes for girls are going to look like this, changes for boys are going to look like this, and it's no big deal. This is just normal, and this is healthy, and this is what we do. And it doesn't become this shame-based thing about, I need to, hide the changes that are happening to my body. I could be celebrated that I'm growing up, you know. If you're getting a bat mitzvah or, you want to be celebrated because quote unquote, you're an adult, or your confirmation. Well, what does that mean? That's not just an event in the church. That's about an event that happens in your life. You're growing up into an adult. That's a body thing. That's a human thing. And so giving that language to parents to say, it's okay to talk about this and we should talk about it. And maybe that needs to happen with, the obstetrician passing it off to the pediatrician to say, okay, you need to have a talk with the parents to tell them about the birds and the bees and what development looks like for a child, so that they can expect this change to happen and not be afraid of it. So I don't know. Did that answer the question?
Yes, you did wonderful. Thank you so much.
Again, give me a platform and I'll talk forever. So back to kind of risk factors, basic risk factors for, developing an eating disorder. So we could say that, if you're a female, Native American, white, or Hispanic, if you have a history of obesity or higher BMI, if you have digestive problems or picky eating growing up, or maybe you didn't eat enough in childhood, you have high risk factors for developing an eating disorder. Psychologically, again, things that could be happening that might impact whether or not somebody develops one. So maybe there's early life trauma, and whether that's about a parent's illness, maybe a physical or sexual trauma to the child or family member themselves, rape, witnessing violence, maybe death or loss of some family member, serious illness, any of those sorts of things. Maybe, I've had patients that they get their wisdom teeth pulled, they're unable to eat because they're having complications. And then somebody, in a misguided manner, unintentionally says, wow, you look great. What are you doing? You look like you've lost some weight. And this person goes, oh, I guess I need to lose some weight. And so they continue this behavior of not eating because that's how they got to where they are. And people say, I look good now, so I just need to keep this up. So we need to be mindful about what our words are and how they could be taken and how they could be, twisted by the eating disorder or the vulnerable mind that doesn't know what's going on. Um, more risk factors. Again, temperament. We talked a little bit about the anorexic and the bulimic temperaments that are going on. So individuals with anorexia tend to be very anxious, fearful, perfectionistic, harm avoidant, shy, obsessive compulsive. These types of personalities are going to potentially lead somebody to be vulnerable to develop anorexia. Likewise, somebody that's more like a hare, they're erratic, they're impulsive, they're novelty seeking, they're reactive, they're chaotic, they're bored, they're, extroverted, they're oppositional, they like complex things, they want a lot, they don't want it, it's overwhelming. That individual may develop, bulimia nervosa or binge eating disorder, so we have to consider what is happening there. Again, psychological risk factors for developing eating disorders in general, low self-esteem or inability to be effective in their life, that sense that, I can't make any difference, low self-evaluation, body concerns. Again, if they don't know to expect that their body's going to change in a certain way, they may be really upset with how it's starting to look, because it never looks like a perfect full-grown body, when it's happening. It's awkward, it's uncomfortable, and it's painful for a lot to, kind of go through that and to say, wow, I feel like a misshapen, caterpillar becoming a butterfly. I don't know if this is ever going to look right. So we want to help them feel okay about who they are, and that their development is not done at 15. It's going to keep going for quite a while. We also recognize that individuals with low social support, limited, maybe family members are involved in a lot of issues going on. Maybe there's other children in the family with difficulties that are drawing attention of the parent from one child to another. So that puts people in a vulnerable place. And again, the comorbid issues of, other mental illness, mood disorders, substance use disorders. And then there's behavioral risk factors. So certainly dieting is among them. Dieting is the leading cause of eating disorders, but also involvement in certain activities or sports or professions that have an aesthetic emphasis. So an emphasis on body weight, shape and size, appearance. So like models, dancers, gymnasts, jockeys, figure skaters. All of these individuals are usually somebody that's being measured on weight class. They have to fit in particular costumes. They're going to be wearing uniforms that show off particular body parts. And so nobody wants to be judged negatively. So they're going to be focused on what they look like in these outfits, or, how people are going to perceive them if they're a performer. And so that's going to influence a lot of what happens for developing an eating disorder. Family factors play a role as well. We see eating disorders, again, across the board, all socioeconomic statuses. Nobody is, off the hook on that. But generally speaking, individual families are going to have a lot of high standards. There maybe is achievement orientation. There's an emphasis on how we appear, and that can be physically as well as emotionally or academically among, peers or the greater community. There's a tendency to expect obedience and conformity. We don't want to rock the boat. There may be, again, more emotional disorders or substance use or alcohol disorders, or maybe a history of other eating disorders within the family. We do see a number of individuals. There's research that shows that there can be at least 2 or 3 generations of an individual developing an eating disorder. Grandma had it, mom had it, sisters have it, aunts have it, maybe paternal and maternal family members have it. So we want to be mindful, if you're doing genograms, to look back on what is going on from previous generations. That may influence what's happening now. Other family factors, again, if you're going to shake a family tree with an eating disorder patient, you're probably going to find that they have issues across history. So again, families with anorexia tend to be very closed systems. They're rigid. There's a lot of control, overprotective. The family members tend to be enmeshed. They're risk avoidant. They don't want conflict. They don't like kids that talk back. Bulimic families, again, tend to be a little bit more disengaged and chaotic. A lot of, additional issues, substance use or trauma going on in the family. So again, individuals with eating disorders are several times more common within biological relatives of other individuals with eating disorders in the general population. And, we just have to accept that, asking that question, if you're a clinician, does anybody else in your family have an eating disorder or a substance use disorder or another mental illness? Being able to address, what's happening in the family. Some of our patients talk about their mom or their dad being preoccupied with their own weight or engaging in excessive exercise. And so maybe they're not diagnosed with an eating disorder or disordered behaviors, but they potentially are influencing what's going on for the kid, because the kid's a different person and they don't look like mom or they don't look like dad. And is the parent being critical or teasing of a child in the family? Again, being mindful about the language that we use. Culture, society also plays a huge role in what's happening. So the changing role of women, attitudes about weight, shape, and size. We can think about, if we look at the art masters in museums, the Rubenesque women with, the natural, roles of fat upon the body, all the way to, Twiggy and, Callista Flockhart and, Angelina Jolie and all these, actresses and celebrities who are tall, thin, and, unreasonably unattainable sizes that our children and our adolescents and sometimes our adults are all looking to as role models. So we have to recognize that, what's going on. And although I know back on that first slide, I said social media is not to blame, it does play a role. We have to look at, we're being inundated with so many messages. But what's important is, again, remembering it's not just about the food. Eating disorders are a coping tool for a lot more serious underlying things that are happening. We touched on it a little bit ago. A way of avoiding growing up, feeling inadequate, a fear of success, or a fear of failure, or there's issues going on with emotions. They're afraid of becoming somebody who's angry all the time, and so they're trying to, suppress that, or they're afraid that their depression is going to lead them, to cry all the time and that they'll never be able to turn off the tears. So trying to numb their emotions, and by restricting their food, they're restricting their emotional experience. We have to recognize that eating disorders are difficult. Again, you can't tell just by looking at somebody that they definitely do or definitely don't have an eating disorder, because again, a lot of the behaviors have been normalized in our culture. People with eating disorders are really, they're high functioning individuals. We see them in the professions, medicine, nursing, attorneys, physicians, all sorts of individuals, teachers, there's just everybody that is out there in life could have an eating disorder. We have to continue to do assessment. We have to continue to ask questions, remembering that an eating disorder may transition over time. Maybe they were anorexic as an adolescent, and now that they're a young adult, maybe they're more bulimic, maybe they're engaging in more binge eating behaviors. We also want to be mindful that a lot of these individuals, again, if they can't control their emotions through food, they may try to do it with other behaviors, less adaptive than that, even by, maybe some self-harm, impulse control issues are of concern. So are they cutting? Are they burning? Could they potentially or unintentionally engage in, a harmful behavior that could lead to their death or suicide? Again, innocent weight loss, if you're predisposed to developing an eating disorder and you get on a diet just to improve maybe your self-esteem or to fit into an outfit for a particular event, there's that vicious cycle, that, positive feedback that you get that reinforces the behavior, leads to the malnutrition, leads to the changes in the brain, leads to the obsession about food, body shape, and size, leads to more exercise, more performance enhancement. And again, it potentially leads to being out of control and being caught up in your eating disorder. Want to make a, kind of an abrupt left turn. We're going to talk a little bit about health at every size, or HAES. Again, this is very brief. This is something that was asked, so I think a lot of people have questions about what this actually is, what it means. I just kind of want to cover some of the basics. So we'll talk a little bit about, what some of the terms are related to it, take a look at, changes across, the industry related to defining what weight or health is, and about dieting and what that is. And also, understanding that health at every size, there's a lot of myths about what it is or what it isn't. I also want to be able to talk about what weight neutral is and the messages around that. This can be very counterculture or confusing. And this is definitely, I mean, we could do a whole presentation just on health at every size. But this is just going to help maybe scratch the surface a little. So again, health at every size, it's a paradigm that's supposed to take the focus off of weight, and by doing so, try to change what's going on in our heads about dieting. So it's a non-diet paradigm with focus on health as opposed to weight. And throughout this, I'll talk about health at every size, alternatively as HAES. These are trademark terms, so that's what little r is about that. They were trademarked by the Association for Size, Diversity, and Health, which is an an organization that promotes non-diet approaches to wellness. So again, we want to pay attention to hunger and fullness cues as a way of guiding our eating behaviors, a way to find pleasure back with food, to satisfy cravings naturally, and trust that your body is going to want to navigate to foods that are promoting health. It's also about healthful movement and being active, not as a weight loss method, but because it makes you feel good and there's benefits to it. And we also want to be able to move the focus off of weight itself and moving towards more positive body image, seeing the body and weight as something that are just a component of diversity, much like skin color or hair color. When we look at messages about health in the media, usually the focus is on weight. So you get messages that if you're thin, then you're healthy, and if you're not, then, if you're fat, then you're not. We want to be able to shift away from that. So the truth is there's a lot more to health than just weight or nutrition and exercise. It's a little bit busy slide, but just to try and emphasize that there are a lot of components, not just diet, not just exercise, that get into the whole sphere of health. So a lot of things to consider. So for an example, if you're on a paleo diet, and I don't know if people are familiar with some of these diets, but this is a very popular one right now. If you're on a paleo diet and you're exercising and you're eating all these nutrient dense foods, you're thinking you're on the right track, but now you're not feeling so good and you're feeling kind of stressed. And maybe you actually feel kind of deprived because you're looking at people eating stuff. And so the question is this behavior that you're doing healthy? you know, is there something missing maybe? So maintaining health is going to be about balance along all of these aspects, not just one, not just two, but balance. So we have to look at limiting lifestyle changes, just focusing on health. So again, you could have the perfect diet, your exercise is on point, and you still get diagnosed with cancer. So it's not just about these particular specific behaviors. We have to look at diet and exercise are just a couple components on the whole sphere of what health is. And so we need to take into effect, again, genetics, society, what's going on in the environment. We're not going to cover this a whole lot here. We defined a little bit about health. So let's talk a little bit about weight. What does it mean to be, overweight or obese? These are categories that are labels that are relative to weight and height. So we talk about body mass index. I'm sure everybody's familiar with that. It's probably on your health portal from your doctor's office. And so what this is a method of categorizing people into 4 primary categories. So you're underweight, you're normal weight, you're overweight, or you're obese. There are a lot of limitations to using BMI as a marker of health. Number one, it doesn't take into account whether or not you have muscle mass versus fat mass. It's not taking into account your fitness level. Or whether or not you're a female or a male. So we have to keep in mind BMI is not a screening tool. It is not a diagnostic tool. And researchers need to continue to look at it as to why it's being used as an indicator of health, because it's really not helpful. So again, you can't tell by looking at somebody's height or weight to determine if they're healthy. So some of my issues with body mass index, again, we need to look at it, that this is, just very subjective criteria. It's not really supported by science. It was invented by a Belgian statistician to look at the average person. So again, this was something 200 years ago nearly. It's not particularly helpful now. It's been used by the medical professionals because insurance company likes it. So they're going to ask for this, but it's really, again, it's not a marker of health. A lot of recommendations for body and behavior changes are about your BMI, but again, not related to actual health. So let's say you're a professional female athlete and you're going to have a higher BMI and be categorized maybe as overweight, whereas a woman, similar age, sitting on the couch, smoking, doesn't exercise, eating just kind of average food, she's going to be considered normal or ideal. So we have to look at what are all the factors involved if we're going to categorize people as healthy or unhealthy or whatever label we might be putting them in. A lot of individuals, a lot of women in larger bodies go to their primary care doctor, and their doctors are going to tell them that based on the BMI, they need to be on a diet. And they're not asking what your habits are or what you're engaging in. I recall a woman that I worked with a long time ago when I was at the med school, and she was hardly eating anything, and her doctor kept telling her that she needed to reduce her calories, and she was starving. she couldn't help it. She's an individual in a larger size body. And despite all the efforts to try to lose weight, she was just an individual in a larger size body. And her doctors needed to learn to accept that. So we have to consider that medical recommendations and treatment interventions should be tied to actual physiological markers, not just weight. So again, what's going on in your lifestyle? Are you a smoker? Maybe that would be helpful to cut back on. If you're not moving at all, if you're sitting on the sofa, maybe taking a walk would be helpful. We need to look at broader definitions. Another thing that we could consider is that there are associations. The CDC says that obesity is related to conditions such as heart disease, stroke, diabetes, cancer. We've all heard this, and what we need to recognize is that association is not necessarily causation. Correlation is not causation. So a correlation simply means there's a connection between two or more things. So if we said, for example, male pattern baldness is correlated to heart disease, does that mean that if you're a bald man that you have heart disease for sure? Absolutely not. We don't know. So it's a correlation. It just means there's a connection or an association. And so what needs to happen is research has to look at well-controlled trials, randomized trials, where individuals are, in a control group or an active intervention group, and that we monitor this over time. And only then could we actually maybe make a jump to saying something causes something else. But without well-controlled scientific, randomized trials, we can only make an assumption. So when they say obesity-related conditions, we could also substitute that to say obesity correlated or obesity associated illnesses. Obesity doesn't cause these conditions. There's just a connection. So what we do know about these is that, again, a lot of factors could come into play with what's happening with whether it's cancer or heart disease or diabetes. We don't know that it's absolutely one thing. There's family factors, there's, movement, there's sociological, there's environmental and work factors. We don't know. We have to be honest about that. HAES is, again, weight neutral. And so it encourages that people are not focusing on good or bad. Weight is not good. Weight is not bad. It's simply a side effect of having a healthy relationship with food and activity and a healthy body image. So this is what is called a YAY scale. And this is a scale that's different than, our traditional scales, where if you step on a scale, a normal scale, the number on that might influence how you're feeling about yourself on a day-to-day basis. But with a YAY scale, it's going to support that, instead you're maybe awesome or beautiful just because, so we have to help individuals, again, HAES, to move to that questioning of what society determines beauty or health are. Is it about being at a certain size or maybe celebrating size diversity? Let's celebrate all bodies. Some myths. Health at every size is that everyone is healthy regardless of their weight. A lot of people think that's what the message is, but this isn't true. Not everyone may be at their weight that's right for their body. So although attempting to understand that losing weight might be the answer, the reality is that we have to provide individuals with a lot of more information, to make positive choices about their health, about exercise, and about food choices, regardless of what size body that they're in. Second myth here, health at every size message is that people shouldn't be concerned about nutrition or activity. Again, that's not what this is. It's not that people should just eat whatever they want and not be concerned. We need to recognize that eating and exercise are important, for good health. But HAES is going to advocate that we support the idea that it's less important as, the whole overall level of fitness and nutrition. We want to support eating based on internal cues, what our hunger or fullness cues are, if we have natural cravings, what those might be, what our body really wants, and whether that's related to activity or food, whether it's play foods or quote unquote health type foods. We need to listen to our body. Maybe it's telling you that you need to sleep, or maybe it wants to go, take a little walk. So we need to move away from that idea of dieting into a non-dieting and eating in response to what our body is talking to us about. That may be hard if a lot of people have been dieting for a while, but it is certainly encouraged and it's possible to change that focus, allowing your natural body cues to come back, your hunger cues, you're listening to your fullness cues, listening to the idea that when you move in a certain way, you feel happier. And myth number 3 here, people who eat based on cravings will only eat junk food all the time. That's again not true. A lot of people wonder that if you actually did that, maybe you'd eat up just all the junk food. And maybe at first you might, because it's like, oh, free license, I could eat all the ice cream that I want. But you're going to learn that if you listen to your cravings and what your body wants, really, um, you don't have guilt, you don't have shame, you're not putting any morality on it. Your body is going to start saying, I really like some cantaloupe right now, or maybe, a nice bowl of soup would be good. It's not about morality in food. It's not food that's bad. It's not what we shouldn't eat. It's just, what our body is saying maybe would be tasty right now. So once you get out of that head game again, and you find that your body is actually, telling you that it wants something that's kind of tasty and fun. And what do you know? It might even be good for you. So kind of, again, the summary, health at every size is about celebrating size diversity, recognizing there's a lot of components to health, not just nutrition or exercise, that are going to define somebody as being healthy, and that we have to take the focus off of weight solely and listen to our bodies to be a guide. I don't know where we are in time. I want to be mindful about that. Um, we have to look at, the best way to help somebody that does have an eating disorder is early intervention. And so, again, being a good listener, encouraging people who may have an eating disorder to consider talking to their healthcare provider, to seek maybe assessment with a treatment facility, to ask and get education, to maybe be screened for their eating disorder. We want to prevent chronic malnutrition or long-term health complications and potentially even death. Detecting and treating eating disorders as soon as possible is the best way that we can save lives. Again, we want to engage in that early intervention. Screening is not about diagnosis necessarily. It's about, making certain that we're getting out there, we're getting information, we're seeing all the potential factors that could be playing a role in this, looking at all the risk factors in somebody's life. We need to consider when we're looking at whether or not somebody needs a higher level of care, if, beyond outpatient, what might be happening. So again, if they're not eating appropriately, if they're continuing to use behaviors such as purging, or they're engaging in extra exercise and more than they're supposed to, they're not gaining weight appropriately, if they've been in treatment, they're avoiding meals, or there's new medical complications, this would maybe be a good time to consider that, they should probably seek help. Other factors involved, again, maybe they're passing out. Maybe there's, their blood work is showing up a lot of electrolyte disturbances. Maybe there's other things. Maybe when they're engaged in their eating disorder behavior, maybe they're seeing blood in their vomit, or maybe they're having seizures, or their heart's, palpitating or fluctuating. We're seeing worsening depression or increased SI or self-harm behaviors or isolation. If you have any concern for somebody, referring them to, an assessment would be wonderful and hopefully potentially life-saving. Our key goals for treatment, again, nutritional rehabilitation. Medicine is the best, we can do for somebody. Well, food is the best medicine when you have an eating disorder. So we want to be able to, support that individuals are getting good nutritional rehabilitation. We also want to help family members, provide support for them, help them understand that this is not their fault. Families are not to blame for, the start of an eating disorder or the cause of an eating disorder. If you're a provider and you're meeting with somebody, whether you're a nurse practitioner, a physician, or a counselor, not an eating disorder specialist, it doesn't hurt to ask some of these questions of somebody that you may have concern about, to ask them, maybe, are you doing anything to manipulate your body, or change your weight? Are you eating in secret? Or, when was the last time that you ate? Are you, avoiding eating? Or, how's your social life? Have you been, staying connected with your friends? Exploring these things with your patients, asking them how they're doing, and encouraging people, again, to seek help if you suspect that there's something going on here. It's really important that we want to try to minimize stigma. We want to increase knowledge. We want to reduce barriers for treatment. And, there's a lot of health behaviors that people have concern about. Again, that idea of HAES, that where people think, oh, it's all about, you can do whatever you want to, you know, debunking some of these myths and helping people understand the realities about what health actually is. If you're a support person or a loved one with somebody, it's really challenging for yourself. And so you don't want to, get into an argument with somebody. That's not going to be helpful, accusing somebody of, engaging in behaviors. But you do want to maybe speak, from that personal place, using your I statements, that I'm concerned about you. I've noticed that you're withdrawing from your friends. I've noticed that every time that we sit down to dinner, you've got an excuse and you disappear to your room. You've stopped, going to the doctor, you stopped going to the dentist. I've seen, that there's some, concerning issues. You've lost weight or you're gaining weight or something, to notice that you're coming from a place of concern and care. If you hit an impasse, if it's not going anywhere, if they're refusing, again, the denial about having an illness, put a pin in it, check back with them, say, maybe this isn't the right time to talk. Let me get back with you, I'll check in with you, and leave maybe some resources, maybe the phone number for a place to call for an assessment. Leave the door open. You don't want to be talking with your friends. A lot of our patients will say, I was just so angry with my mom. She talked to all of the family members that I have this problem, and everybody knows, and everybody's posting it online, and I feel like, a bug under a microscope. We don't want to do that. We want to avoid gossiping. You're not the food police. That's not your role. You're a loved one, you're a caregiver. You want to be appropriate. But we also want to recognize the difference between keeping secrets and being, keeping somebody's confidence and saying, okay, I know that you have this difficulty and I want to help you with that. Who are you comfortable with me sharing within the family? The family's got a lot of concerns for you. And maybe it's limiting, we've been checking into this, thank you for your concern. We appreciate your thoughts. And, something very limiting, as opposed to it's posted all over Facebook and complete strangers are walking up to them at school and asking them about their illness. We want to be monitoring that. We want to be mindful about boundaries. We also don't want to oversimplify and say it's just an eating disorder. It's a phase. They'll get over it. They'll grow out of this. Sometimes people don't grow out of these things. Sometimes people die. Some do's and don'ts for therapists and family members. A lot of people are worried about saying something, the wrong thing. They don't want to make things worse. But instead they don't say anything at all. They're walking on eggshells. And so, I can make this handout certainly available for you. It has a lot of good suggestions on here about being supportive, about expressing care without, making undue comments. If there's time, I'll just talk real briefly about ED Care and who we are. We've been around since 2001 and in Kansas City since 2015. We're Joint Commission accredited. We are an empowerment-based treatment program. We take patients from all over the country, really. We have a multidisciplinary team, so psychiatry, medical, individual therapy, family therapy, group therapy, nutritionists, dietitians. We are individual and group therapy focused. We have our own philosophy that we call CAMSA. It's empowerment based. And so what we encourage people is to have a connection with individuals, with themselves, to build connections among their peers, to work on acceptance, accepting first, that they have an eating disorder, but also that they are entitled to have thoughts and feelings and strengths and weaknesses, just like anybody. That they can practice being mindful and aware and staying connected in the moment. Creating a sense of self and an identity that's apart and separate from having an eating disorder. They are so much more than just an anorexic or the bulimic girl. They have opinions and beliefs, and they are a wonderful individual that people would love to get to know. And the ability to take action, to apply skills that they're learning in program into their real life to sustain recovery, and recognizing it takes a lot of practice. And so the team is here, we're here to help let people go on, with their lives. There are a variety of levels of care. The ones with the stars are the ones that we offer: outpatient, intensive outpatient, and partial hospital. Our Denver program will be opening a residential treatment program in the near future. So these are available here. Um, we are a partial hospital for adults and adolescents. So our adult program is 6 days a week. Our adolescent program is 5 days a week. So we take individuals from 13 to 17 in the adolescent program and 18 and up in the adult program. And individuals transition from PHP to IOP. And we also have an evening IOP available for those who are maybe still working or in school. For some individuals, they need a little bit of support with housing. Maybe they live at a distance, or maybe their home environment is not supportive of recovery. So we are able to accommodate for individuals in a nearby apartment, which is peer supported housing. Our slide about our program here, again, it's 10 hours a day, 6 days a week. Multidisciplinary team. So people are seeing their individual therapist a couple times a week, and everybody else at least once a week. Lots of groups all through the day. They're evidence-based treatment programs, DBT, CBT, ACT, as well as experientials, cooking exposure groups, body image, addiction, sexuality, grief and loss, healthy relationships, communication. Our IOP in a similar way, all of the same programming, just a shorter day, 6 days a week with gradual step down. And then our evening program, again, Monday through Thursday for about 4.5 hours. It's about 10-week rotation of program. Patients, have dinner with the clinician in EIOP as well. We encourage them to continue working or to be in school so that they can live their life and practice recovery skills. And here we are, just about at my last slide. So, some 9 truths again about eating disorders. We don't want to blame anybody. Families are not to blame. We need to be able to see them as support persons. A lot of people with eating disorders look healthy, and yet they can be very, very ill. So we don't want to forget that. We can't tell just by looking at somebody. A diagnosis of an eating disorder is a health crisis. It can potentially lead to death. We want to take it very seriously. Eating disorders aren't choices. They're biologically influenced illnesses. They affect everybody, no matter who you are, where you come from. There's an increased risk for, lethality, suicidality, medical complications. So we want to be mindful about that. They're multifactorial: genes, environment, society, all sorts of things play a role in what's going on. And genes alone are not going to predict who's going to develop an eating disorder. And lastly, recovery absolutely is possible. We have to do early detection, screening, and intervening. Catch my breath. So I can stop sharing. I don't know. Is everybody still there? Are there questions?
This is incredible, and everybody is still here.
Yes.
Thank you so much. I've got 14 questions. So as you were presenting, I put them in categories. So
Okay.
I'm going to try to loop some of these together. So hopefully no one's too upset with that. The first one, we had a couple people ask about Ozempic.
Okay.
And how it potentially relates to disordered eating, what we know about that, and the conversation we have. So let's start with that question.
Wow. Okay. And that's a kind of a hot button thing going on right now. It's becoming the new celebrity diet plan. It's a semaglutide. The thing about Ozempic and other medications like that, they're rather new, but they're specifically for individuals with diabetes, with the type 2 diabetes, not just, somebody that's a little on the heavier side that doesn't have that medical complication. It's like the type 1 diabetic who needs to take insulin. This is a lifelong medication that's going to be necessary. we don't know what the long-term effects of it are yet. They're still doing research on that, and physicians that are working with patients are free to recommend that. They're saying, we're still trying to monitor what's happening. It's very closely monitored by physicians for individuals who it's appropriately prescribed for. The problem with it being taken by somebody, like, these celebrities or just, the average Jane or Joe out there is that if you don't have that complication, you might experience short-term weight loss, which seems like, again, wow, that's reinforcing. I'll keep doing this. But you can't keep doing it because if you stop, it's much like the Rogaine kind of thing. Your weight's going to return, and we don't know what that's going to look like. Kind of in a similar way, a lot of people went through a phase of getting liposuction done. Well, what they found for individuals that was not something that was prescribed and quite appropriate for medically is that, yes, it removes the fat cells from one area of the body, but you know what? The body's going to respond back and it's going to say, so there, I'm going to show you. And so fat cells grow back in other areas of the body, and it's not attractive. It's like, okay, it's not in this one area, it's, but it's all around that because the body wants to restore that homeostasis. And so if you're not an individual that it's prescribed for, you're taking it for short-term, results, that's potentially a very dangerous slope to be on. And so I'd say, talk with your primary care doctor about your risk for diabetes, type 2 diabetes. Is it really something indicated, or could you maybe engage maybe again in lifestyle changes more broadly than just looking for a quick fix?
Thank you so much.
Oh,
You also talked throughout about the importance of early intervention, early diagnosis. So throughout, we put the chat in, or the information in the chat about your free and confidential assessments.
yes.
So if anyone missed that, please go back in the chat. I'll reshare. But could you share with us a little bit about what that free and confidential assessment would look like for somebody who is interested in getting that?
Absolutely, absolutely. So it is exactly that. If you think that, maybe, I have an eating disorder, I don't know. Calling into our number, talking with one of our admission clinicians. So we have two on staff here in Kansas City, Siobhan and Michaela, and they're very qualified clinicians. They will do this interview with you to ask about your history, about what's going on for you right now, what your, concerns are that, has brought you to this, question, do I have an eating disorder? And they'll ask an in-depth, interview with you, spending at least an hour of time with you. At the end of that, they're going to be able to develop some good information about whether or not you qualify based on diagnostic criteria. Do you have an eating disorder? And if so, based on what's going on for you, they may say, you might, be an appropriate individual for our treatment program. Let's do the next step, which would be to get a medical clearance, and let's have some numbers from your physician. So they're going to be referring somebody out to get blood work done, an EKG done, you know, a full workup. What medications are they taking? And that will be brought into helping understand what is going on for this particular individual, and would they be appropriate to admit to partial hospital, which is our highest level of care here in Kansas City for ED care. If maybe somebody has been struggling with their eating disorder and they're not appropriate for us, maybe they need higher level of care, our clinicians are going to give, a recommendation for resources. So we could say, there's a residential program, where are you located? Let's try to find that for you. They'll give you that referral information. Or maybe they're saying, there's a lot of things going on for you, but it seems like maybe you could benefit from more support in the outpatient. Here's a list of outpatient providers who are eating disorder specialists, and they might be able to help you in a least restrictive environment. We don't want to put somebody in, partial hospital programming 10 hours a day, 6 days a week. If, they've just kind of got a little bit of behavior going on, maybe they just need some extra support in an outpatient setting. And so we'll offer them that. If, they are certainly appropriate, but maybe this isn't the right time, again, no obligation. Here's our information when you are ready. Maybe they're at school, maybe they don't want to take a break from school, maybe they're getting ready to move across town or move to another location. Okay, here's, you're moving to Chicago. Here's the name of a treatment program in Chicago. We can get you that information too. So we will provide resources, whatever is needed. If it's primarily a mental health issue, not an eating disorder as a primary, they'll also give resources about that.
Wonderful, thank you.
Yeah.
And I apologize, I'm grouping these. So I've got a two-part one coming
Yeah.
up. So the first part is, what recommendation would you have for someone who is struggling to access care due to the BMI restrictions with their insurance and the medical practices taking place? So that's the first part.
Okay. With the BMI restrictions. So generally speaking, you know, we have individuals in a variety of the BMI, kind of the full range. We have very low BMI as well as high. Depending on what's going on, a very low BMI may require higher level of care, potentially residential or inpatient. We want to be mindful about that. Um, if if that's the issue. Most insurance, if they do have benefits that cover eating disorder treatment, and because of mental health parity, most insurances do cover some eating disorder treatment. We usually don't have any difficulties being able to get appropriate support for admission for treatment. If we don't, if we're not contracted with a payer, we may be able to make a single case agreement to get that person in. Or again, maybe it's not covered here, but maybe our facility in Denver might have that coverage. And so that might be an option there. But we've been pretty successful with getting single case agreement, whether that's for something like TRICARE or a Medicaid or a Medicaid Medicare issue, or one of the newer marketplace insurances that we're maybe not too familiar with. If they have behavioral health, coverage, that's usually something that we can work with.
Wonderful, thank you. And actually what you just shared ties into the second part of that question. Colorado recently passed legislation or new law that prevents health insurance companies and the state medical assistance program from using BMI in order to, as a criteria tool for level of care. Do you foresee Kansas passing similar legislation?
Wow, I wish I had that crystal ball. I don't know. I do think that, states are going to be watching what happens, much like, the cannabis industry and, kind of what started a rollout in Colorado has kind of trickled down to neighboring states and all of that. And I think healthcare in a similar vein is maybe going to do that. I certainly would hope that, we get Medicaid expansion before we start having limits on, who can or cannot take advantage of treatment. But I think, yeah, I wish I could see that crystal ball.
I appreciate that. Thank you so much. Let's see. I'm going to transition to some specific questions about eating disorders. This might be a big one. Should I be concerned about eating disorders or having an eating disorder if I'm doing intuitive eating?
Well,
or not intuitive eating, sorry. If I am doing, I think what they mentioned or were meaning to mention is time restricted
like
diets. Intermittent fasting, I think is what they were probably referencing.
Yeah, that can be a concerning thing. The thing to keep in mind about our bodies is they're pretty remarkable, systems. I hesitate to call it a machine, but they're, it's kind of like your oven that's self-cleaning. We are self-cleaning systems. Cleansing is not necessary because your body does that itself. It doesn't need to have special foods or liquid diets or something like that. There's a lot of talk about doing intermittent fasting and what that might look like. And different people are doing different things and calling it intermittent fasting. So I'd be very cautious to say yay or nay that that could be an eating disorder. But if you're eliminating large groups of food, your variety of food, your exposure to eating across the day, it potentially could lead to an eating disorder. Certainly disordered eating, and potentially some physical consequences. You know, a lot of our patients, as I said early on in the presentation, you know, they'll report that they're vegan or they're vegetarian or they're gluten-free or, you know, they're not dairy or whatever, and they've eliminated all of these foods out of their diet. And over time, your body stops practicing, you know, how to process that stuff. Now, that doesn't mean that you're allergic, and it doesn't mean that you have a sensitivity to it. It just means that I'm not familiar with that, you know, or I used to be. And so you have to reintroduce these foods back into your diet. And so intermittent fasting, if it's done for something like, okay, we're doing an allergy test and we want to challenge whether we have an allergy to egg. So we're eliminating foods that have eggs in it, just eggs, maybe. Well, that might be one thing. But if it's like, okay, we're going to eliminate eggs and dairy and, you know, proteins and white flour, and, you know, it's like, wait a minute, you're eliminating a whole bunch of things, and scientifically, you don't know which variable is causing you distress. You know, and so it's really important to talk. I'd say, you know, find a nutritionist, a dietitian who has a certification as an eating disorder specialist in nutrition, and to talk with them about what's going on with your food, why maybe intermittent fasting seemed like a good idea, or why it was recommended for you, and to try and understand that.
Awesome. Thank you. And then this last one, I'm going to group 3 questions into one. I think we can capture all of that
Okay.
in saying, so we're coming up on National Eating Disorder Awareness Week. I put those dates in the chat earlier, and we had some people who expressed a lot of interest in getting involved in supporting somebody or with an eating disorder or the work. So if there was one action step that you would leave all of us with, what would that be, and why would that be the one that you selected?
Wow. Okay.
I know, sorry.
Which favorite child do I have? You know, I think, you know, keeping in mind, much like the Hayes experience, health at every size. We're not, you know, if you get a chance, and you can put this in the chat, poodle science on YouTube. Look up poodle science on YouTube. Sarah, maybe you could share that in the chat. We want to have size diversity and acceptance about individuals, no matter what's going on, because so many individuals are trying to manipulate and change and massage themselves into what they believe other people want. And instead of just accepting us who we are and as we are, we are all wonderful people, and we all have gifts, and we all need to be celebrated. And so I would say, you know, really encouraging people to be mindful that there's no good foods, there's no bad foods, there's, you know, no right way or wrong way to have a body. Everybody is a good body, you know. Different people as they move through life, you know, you start out as maybe an 8-pound baby, and you're going to grow up and you're going to become a 6-foot tall person, and you're going to have a body. And whether you're at an average weight, a low weight, or a high weight, we don't know. You know, what are you doing in your life? You know, who are all your people? You know, are you, you know, from Viking stock or Amazon stock, or are you, you know, from, you know, little Colombian, you know, individuals who are, you know, indigenous persons from the mountains, and they're very tiny. We don't know. And so allowing that we could, you know, have any influence in our genetic pool. And so it's all okay.
Awesome. Thank you.
Much like mental health for all, I like your logo there. You know, just acceptance for all.
Awesome. Thank you so much. And I think, you know, that was our final question. So I think that really goes to show again that help is available, healing's possible. So wherever you're at tonight, again, get connected with ED Care, whether that's a free and confidential assessment. That information's been shared. I'll also reshare your wonderful resource page with literature, resources, all of that. So I encourage everyone tonight to continue your learning and reach out for support, and together we can really break that stigma and shame by having the conversations and encouraging help-seeking behaviors. So thank you so much for your time tonight, for educating all of us and just reminding us that it's okay to have the conversation and to get support.
Absolutely, absolutely. So thank you very much, for the invitation to come and speak to you and your audience, and just kind of share some information about eating disorders. What can we do to spread the word? Get information, learn as much as you can about eating disorders, about prevention, about screening. When you go to the doctor, protest. No, you don't need to take my weight to, check my eyes. I'm coming here for a splinter in my hand. I don't need to know my weight, and please don't tell me. We don't need to create anxiety for things that are just, kind of normative.
Wonderful. Thank you so much. Thank you again to everyone who attended, and know that we're all here for you in any way that you need. And I hope everyone has a wonderful night tonight.
Thank you so much.
Thank you. Thank you very much. Good night, everyone.
Thank you.